Amblyopia. So you will see about what is amblyopia, various causes of amblyopia, classification, and various treatment modalities. What are the options available for amblyopia, and role of optometrists. So what is amblyopia? So common என்ன சொல்லுவோம், lazy eye, சோம்பேறி கண்ணு அப்படின்றது. So first as an optometrist நீங்க தான் refraction பார்க்குறீங்க. So நீங்க எப்படி amblyopia-வை diagnose பண்ணலாம்? So what is amblyopia? Commonly referred as lazy eye, defined as a reduced best corrected visual acuity in one or both eyes, which are structurally normal, and it is caused by a abnormal binocular interaction during which the critical period of visual cortex neurodevelopment. So in the picture, the first picture, so it is having normal BSV. So the two cats are, the images going to the brain simultaneously. So second picture, what is happening? So one cat is clearly going to the brain, and the next other eye images, it is blurred because of anisometropia. Other eye is myopic. So what are the causes? Based upon the possible causative factor, so amblyopia can be classified as strabismic, refractive, and visual deprivation, or mixed kind. So refractive, anisometropic, or bilateral refractive error can be there. So it is associated with the mixed type is also there, both visual deprivation and also strabismic. So children under 8 years of age are at high risk of amblyopia. So why it is associated with significant morbidity in terms of lifelong poor vision and its adverse effects on quality of life if it is not treated early. So early detection and treatment is at most very, very important. So strabismic is mostly caused by squint, esotropia or exotropia, hypertropia or hypertropia. Refractive amblyopia caused by refractive error, anisometropic amblyopia, emmetropic amblyopia, or meridional amblyopia. So stimulus deprivation, as we all know, it can be caused by cataract, corneal opacity, any forms of visual deprivation that occurs in the critical period of time. So a little bit detailing we will do in types of amblyopia. So in constant squint, the patient will use only one eye. என்ன நம்ம explain பண்ணுவோம். So esotropia or exotropia patient 2 years old, 3 years old வரும்போது we will advise patching. So to prevent amblyopia, we will ask them to do alternate eye patching. So என்ன சொல்லுவோம், ஈசோட்ரோபியா இருக்கும்போது ஒரு கண்ணு நேரா பார்க்கும்போது இன்னொரு கண் வந்து ஈசோல இருக்கும். ஸோ ஒரு கண்ணோடைய கிளியர் இமேஜ் வந்து பிரெயினுக்கு வந்து நல்லா ரிசீவ் பண்ணும், இன்னொரு ஐயோட இமேஜ் வந்து பிளர்டாக போகும். ஸோ பேட்சிங் பண்ணும்போது ஸோ ரெண்டு கண்ணும் ஆல்டர்னேட் பண்ணி பார்ப்பாங்க. ஸோ ரெண்டு கண்ணும் ஸ்டிமுலேட் பண்ணும். So in this picture, squint is in the left eye. So slowly, or a blurring of vision, a blurred image போகும். So brain will suppress the left eye. Eventually, it will become amblyopic. So to prevent this, we have to give patching at a very early stage. Refractive amblyopia, this type of amblyopia occurs in the eye having high degree of refractive error. So aniso hypermetropic amblyopia, aniso myopic amblyopia. So in this example, right eye is having 6x vision, left eye 6/60 with +3 diopter, causing an amblyopia. It is only improving to 6/24. So other scenario, one eye is having 6/6, other eye is having 4/60 with -5 diopter. It is improving to only 6/12. So isometropic amblyopia. So both eyes will be having the same refractive error. Hypermetropic more than +4. So if both eyes having more than +4 diopter, it will cause amblyopia in hypermetropic patients. While in myopic, more than -6 diopter. So in this example, you can see both eyes are having more than -8. So it is not improving beyond -60, 6 by 6, 18. So meridional, the same. The one eye is having 612 with -1 cylinder. So other eye, it is having -4. So what will you do if there is an anisometropia, -1 and -4? What will you do? The investigation part I'm asking. So the retinoscopy is showing this. So next investigation to rule out keratoconus. So you have to do K reading. So you have to keep in mind. So stimulus deprivation amblyopia caused by cataract, unilateral or bilateral, corneal scar or opacity involving visual axis, any kind of drooping. So how will you diagnose? Comprehensive ocular examination is always required to rule out squint, refractive error, and media opacities. So visual acuity of the either eye, fixation of the either eye to be noted and recorded, glow of the other eye to look for any gross, refractive error, and media clarity. Refraction and cycloplegic refraction, both 4-dot test, cover and cover test with the no presence of any phoria, tropia. So Brugner's red reflex test also we can do, Bagolini striated glasses and fundus examination. The comprehensive eye examination is always mandatory to arrive at the diagnosis of amblyopia. So how will you grade? So depends on this grading, we have to initiate the treatment. The intensity of the treatment varies with the grading of amblyopia. So mild visual acuity of 6 by 9 to 612, moderate 612 to 636, and severe it is worse than 636. So why it is so important to manage amblyopia? So as the child grows, attains visual maturation, the success of amblyopia decreases. So if left untreated, going to cause a permanent visual loss. So binocularity also plays a very important role in certain jobs like pilots, astronauts, those who are going to use microscopes, so Indian armies, navies. So even otherwise, a person who has binocular single vision is very lucky, and it is very important to have a BSV. So what are the treatment available? So strabismic amblyopia, we have to immediately start patching to stimulate the amblyopic eye to stimulate, and followed by squint surgery. For refractive amblyopia, first we have to give best glasses, optical correction. After 4 weeks to 6 weeks only, we have to start other treatments of amblyopia. For stimulus deprivation, we have to treat the cause. If cataract is there, we have to treat the cataract. Any media opacities, any ptosis needs to be corrected, we have to correct it. So management. So patching, optical correction is the primary treatment. If at all correction is needed, then patching or occlusion therapy, pharmacological penalization, and optical penalization. So dichoptic stimulation, recently Binox BV computer-based therapy is gaining popularity. So this is the gold standard, and it is very, very effective treatment. The success of amblyopia therapy is multifactorial. So I'm repeating this, depends on age of onset, cause, severity, outcome of previous treatment, if any. It all influences the success of amblyopia. So they have conducted a pediatric PEDIC study, pediatric eye disease investigator group. They have conducted a large randomized control trials evaluating the effectiveness of treatment modalities. So they have given guidelines like amblyopia treatment studies till ATS 1, 2, 3 till 20 it is there. They have compared full-time patching versus part-time patching versus 2 hours patching. So everything they have done and given consensus. So optical correction, As I said, sometimes even simple spectacles improves the visual acuity and treat amblyopia. So after 6 weeks of refractive correction, occlusion therapy should be started. So some cases refractive correction alone improves visual acuity in many cases. So it is the mainstay of treatment. So as I said, in moderate amblyopia, patching children 2 hours per day produces the same visual gains as prescribed dose of 6 hours. So part-time 6 hours patching is as effective as a full-time patching. So as I already said, age at initiation of treatment, level of initial visual acuity, type of amblyopia, occlusion time, and compliance. Follow-up and compliance, parents' cooperation is very much necessary. So here it is active vision therapy. Children are engaged to do an hour of near activity during the time of patching. So children can be encouraged to use the amblyopic eye. So after occlusion of the eye, one eye, the children are encouraged to do these kind of activities like clay modeling, reading, writing, painting, or any craft work. Sometimes watching television, video games also we can encourage them to do. So these are all the activities we ask them to do in OPD sometimes. So see, they have beautifully done a clay modeling. So penalization. So we have pharmacological penalization, optical penalization. So when do you give penalization? If patient is not compliant to occlusion therapy, so any allergic issues are there for patches. So for maintenance therapy also we can start this penalization. So these are all computer-based exercises. So now recently many software-based programs are available now. This is Binox computer software. It's like a computer game. It's playing a computer game. Daily they have to play for 45 minutes. Minimum 30 sessions daily, 30 days they have to do using a low and high contrast colors. So contrast adjusted images are present to both the eyes. The normal eye will be receiving the low contrast compared to the amblyopic eye. So this unblocks the suppression of the weaker eye by the stronger eye in ocular dominance columns of the occipital cortex. So here the child is playing super car game in Binox with red-blue goggles. So this is BV therapy, virtual reality therapy. This is again gaining popularity nowadays. Children are very much eager to try these. This is very small 6-year-old child. So advantage of virtual reality therapy, we can give therapy even with smaller squints. So up to 12 prisms, we can incorporate prisms in this virtual reality camera. So Binox, it is not available. With Propia, we cannot give Binox. So here the child is trying to hit the snowball thrown by the snowman. So we can change the background color, size, and transparency of the snowball also. So even with small angle strabismus, it can be given. So literally there are A to Z in the management of amblyopia, atropine, Binox, many drugs like ceticolin. So many are available. That's why I chose these A to Z puzzle. So, but mainly patching is the gold standard treatment. So planning on management, it is very important to note the grade of amblyopia, type of amblyopia, and the age of the patient before planning the treatment. So proper and careful refractive correction is essential in all types of amblyopia treatment. So large anisometropia or refractive error, contact lens may be the first choice. So you should try large anisometropic first we have to try contact lens, and then after 6 weeks, and we can start amblyopia treatment. So for children less than 3 years of age, refraction needs to be repeated at least every 6 months if we suspect amblyopia. So regular follow-up is another big challenge, and compliance also another big challenge. So which is better? The patching, it is easy to understand, economical. So all these computer-based therapy, the one should have good Wi-Fi connection, good laptop system. So everything is necessary for computer-based therapy. If patient is affordable, parents are affordable, we can give. So again, compliance. Computer-based therapy, compliance is better, but it is expensive. So what is the role of optometrist? We will be the first person to see refraction, vision. We can aid in the diagnosis of amblyopia. So we have to own up the problem and educate the parents about consequences of amblyopia. So sometimes one eye will be 660, 4/60 or 5/60, other eye will be 6/6. So we have to safeguarding the non-amblyoptic eye is a bigger challenge. So we have to give safety glasses, polycarbonate glasses for protection. So everything we have to counsel them. So when to refer to a specialist. Thank you.